Changes Jadoon, can you hear me? If you can hear me, can you switch on your video also, please? Yeah, we can see you now. So, welcome to everybody. Welcome, Dr. Changes Jadoon. Can you hear me, please? Audience, can you hear Dr. Jadoon? Can somebody answer in the chat? Candidate one,
No, sir, I can't hear him.
Dr. Jadoon.
Try now. Okay, can you hear me now? Dr. Sami, can you hear me?
Yes, I can hear you. I can hear you. And candidate one, you could hear Dr. Jadoon?
Yes, sir.
Okay, so welcome to every one of you, and welcome to Dr. Changes Jadoon. Dr. Jadoon is a very experienced neuroradiologist, actually an interventional neuroradiologist. And of course, he'll go through some neuro cases today. Today, we have got three candidates, and each candidate is going to be given about 40 minutes. So, and so without wasting more time, I hand you over to Dr. Jadoo.
Okay, let me share the screen. Okay, can you guys see my screen?
Yes, sir.
Okay. Okay, so this is a patient. Okay, so how do I give a control to you so that you can scroll that screen? Let me just. I'm trying to figure out how do I give you control so that you can scroll through. Okay, can you scroll? Is it possible? Can you scroll?
I'm trying, sir. No, I can't.
Is there something on your side that tells you?
Um,
Okay, doesn't matter. No problem. Let's go the old-fashioned way. No problem. Okay, so this is
Okay, just one second, Dr.
yeah,
Jadoon.
yeah.
Those of you who are candidates, there is a method to ask for mouse and mouse control. So if you can ask each other, but for the time being, we'll not waste time. Dr. Jadoon can scroll the scan for you, but all of you should know how to ask for a mouse. Candidate 2, do you know how to ask for a mouse? Okay, Dr. Jadoon, I think best is for you to scroll
I'll
yourself
scroll through. I will scroll.
and ask them the question. Okay, then.
Yeah,
Thank
no
you.
problem. No problem at all. So this is a patient who has come to the radiology department with a history of pelvic and visceral suspected injury, and this CT is part of the trauma series because there was a road traffic accident. So I will start from the vertex and I will gradually scroll for you so that you can see. So please tell me when you pick up something. So I will keep scrolling. So you have to have a system when how you scroll. Either you go from bottom up or from the vertex down. So I've, for your convenience, I've gone from the vertex down. So I'm gradually scrolling.
okay.
So please tell me when to stop or to do anything or change window or anything. I'm more than happy to do it. So I'm scrolling as you go along. So keep describing things for me so that you and me we keep interacting.
Okay, sir.
Yeah.
So, so this is I've been provided with axial sections of NCCT brain of this patient who has sustained trauma, uh, and here I can see that uh,
Yeah. Carry on.
um, the left vertebral artery looks a bit dense to me, and can you show me the level of the basal ganglia, sir?
Yes. No problem. Yeah.
Just below it, the left MC also looked a bit.
Yeah.
Yeah, the left MC also looks a bit dense to me compared to the right side.
Okay.
Um,
Yeah. So
Besides
I'm
that,
yeah. Carry on. Carry on.
and
What
the
is the other
brainstem.
structure? What is the other structure? If you're thinking MCA is dense, what is the other structure you will see along with it?
I look at the basal ganglia region,
Mm-hmm.
um,
Yeah.
but I don't see any obvious hypodensity. But there's some difference in attenuation on the left compared to the right side.
Okay.
There is some and
Yeah.
as we come down, the pons also looks a bit hypodense to me. So with these findings, I'll suspect some ischemic insult to the patient. Although in a trauma case, um, it's rare to see such kind of finding. But with these findings, I like to discuss the case with the clinician, the condition of the patient, um, the patient has presented with, and although there is no obvious bleed which I can see in this trauma patient.
Okay.
Uh, so with these findings, I like to convey my findings to the clinician on an urgent basis, and then I like to go for MR scan
Okay.
to
Okay.
further assess the brain parenchyma, because there's definite some difference in attenuation on the left compared to the right side, and the
Okay.
pons also look a bit hypodense to me.
Okay. So basically, what you are saying for the audience, I will sum up your findings before I go on to the scan. Your findings were that the MCA is dense and there is a change of attenuation between the two basal ganglia, and you could see a bit of a low attenuation in the pontine region. Am I correct? Have I got it right?
Yes, yes, sir.
Okay. And you also said there is no
No
hemorrhage
obvious
in
bleed.
the
Yeah, yeah.
on
There's no
the
obvious bleed which I can see, and although in my routine practice, also like to see the bone window as well to look for any fractures.
okay. So in your practice, you would want to see the bone window of this. So here is the bone window for you. I'm going to go to the vertex. So you are looking now at the bone window.
Yes, sir.
Okay. So you are looking, keep describing so that the audience
Okay.
keep listening.
Okay. So till now, I've not been able to make out any obvious fractures in
Okay.
this patient. Now I'm looking at the basal sections, and here also.
Correct. So keep talking. Yeah, it's always good to.
Yeah, the basal sections are also not showing any obvious evidence of any fracture which I can see. I don't
o-
see any obvious fractures, yeah, in the bone window.
Okay. So for the audience, candidate number one has not been able to pick up any bony fracture. So in a trauma series, he's right. You look at the parenchyma, you look at for the bleed, and you look at for the fracture. But do also keep in mind you need to look for any incidental finding that is there. So the most important thing that candidate one should have noticed was, if you look at here, the left petrous bone is asymmetric. The one side is up, the left side is up in comparison to the right side. So that has a bearing on how you see the brain parenchyma. So I am now changing the windows. So look at now, you can see this side of the brain generally on the left side is a bit more whiter than
Yeah.
the right side. So whole hemisphere is whiter than the other side. So you can't have a, so that is the reason why you are seeing these changes in the basal ganglia. So always look at the symmetry of the brain. If you do not have a symmetry, then you need to reconstruct the images so that you have got a symmetrical images. So that's number one. Number two, the other thing that is important is that you should also look for symmetry of the sulci. So here, look at, so I would want you to look at now comment, candidate one, I would want you to comment on the symmetry of the sulci. So have got sulci here, you've got sulci here, you've got ventricles, very symmetrical. You've got Sylvian fissures, which you can see, although one side comes above the other. You can see prepontine cistern region. You can see the fourth ventricle very much. But where is the obex of the fourth ventricle? What is happening here? So candidate one, what do you describe this area more for me, please?
Um,
So describe me where I am putting the arrows. So what is this structure?
um,
This is the lower
this is
pons
the
medulla.
there's lower pons and medulla, yes, sir.
Okay, so what is this structure where I am drawing the arrow? This is called cerebellum. Of course, this is
Yes,
cerebellum.
yes,
Or
yes, sir.
what is this structure in here, which is pushing the medulla forwards? What is this structure that you can see, which is same density as you can see the pons and the cerebellum? And what are these structures in it?
Uh,
Is it normal?
I'd like to see that in the sagittal sections if possible, because
So you want to see sagittal sections. Okay, so here is your sagittal section. What do you see now?
I can see a lesion over there, which is having some calcification focus within it as well, and it is indenting the medulla and
Okay,
compressing it.
so what does that mean?
It could be an incidental finding, which could be a neoplasm.
Yeah, okay. So this is how it is looking at what you were seeing. Yeah, what sort of a neoplasm can you think of?
So, can I know the age of the patient?
The patient is, what do you think? In exam, the images are anonymized. So what do you think the age is from the
Uh,
looking at the scans?
so,
There
looking
are
at the
three.
scans, feel the patient is like middle aged.
Yeah, that's fine. Yeah, correct.
So considering that, it can be it can be a glioma or
So what sort of a glioma will happen in the, so the most important thing that you have to in brain, all types of tumors, there are three types of tumors that happen. One, in the brain parenchyma, two, on the dural lining, and three, outside the dural lining. So remember, for all the audience, remember in brain, you can have a brain tumor in the parenchyma, on the dura, or outside the dura. So this is how the surgeons look at or at things. Is the tumor in the brain? Is it in relation to the dural lining, or is it outside the dura? The surgical
looks like,
approaches change according to it.
this looks like that is outside, probably outside the dura.
It is outside the dura. So how will you confirm it is inside the dura or outside the dura?
I like to proceed with a contrast study, or maybe an MRI scan with contrast.
Okay, okay. So co- co- do for all the audience, remember, if you have to give contrast on CT, it is better to give contrast on the MR, so that the kidneys are not put under stress in a tumor situation, because in modern day no surgeon operates without, you're taking a British exam, no surgeon, neurosurgeon will operate without an MR on a tumor. It does not happen. So okay, so we have got an MR. If you want to do an MR, what sort of an MR you will do, what sequence you want to, you ask me the sequence, I'll give you the sequence.
Um, I like to
What would you do?
initially I would like to look at the T2 and
You want to see T2. Okay, so here
yes.
is your T2. So here is your T2. We are on the foramen magnum region.
Again, I can see here the same lesion, but
Yeah,
it is showing heterogeneous signal intensity on the these T2 weighted axial sections.
okay,
Besides this, I would like to look at the contrast images also to look for
okay.
any, if it's extraaxial, I'd like to look for whether it's having a dural tail or not, to rule out a
So,
possibility of meningioma.
okay, so what your description is telling me that in remember, in exam you have to tell the examiner that I am a methodical person and I have a system in my mind when I look at the MR. So from here you straight jumped to the post contrast. The the normal system is you look at the T1, you look at the sagittal, you look at the coronal,
Yes, sir.
non-contrast, then you ask for contrast. So there is a system that you go through. So in
Yes, sir.
exam, you have to go through the same system that you have in your day-to-day life. Exam is no special. You
Okay.
only go through the same system that you have in your day-to-day life. So
Okay,
what
sir.
other non-contrast sequence would you want to see?
Besides this, I like to look at the T1.
What sort of a T1, axial, sagittal, coronal?
Initially T1 axial.
Initially T1 axial. Let me see if I have got axial T1. I do not have an axial T1, though I
Then
have got a sagittal T1.
yeah.
So,
So here again, I can see that there is a mass which is there in the posterior fossa in the
mm,
inferior portion, and it is further insinuating into the foramen magnum region, and
yeah,
it is seen compressing the medulla and the cord, which is lying anterior to it. So it is. Um,
yes.
so it is further
So,
insinuating.
so here is my question to you.
Yes, sir.
Is this lesion in relation to, you have said it is separate from the medulla and the cerebellum,
Yes, sir.
sorry, medulla and the upper cervical cord, but
Yes, sir.
is it separate from the cerebellum or not?
Uh, so this lesion seems to be arising from the inferior portion of the fourth ventricle. In fact, the cerebellum also looks separated and looks a bit superiorly
Okay,
pushed.
so it is a lesion
But
which
I would
is,
like to, sorry,
yeah,
sir.
yeah, go ahead.
But I would like to further see the other sequences which have been obtained before.
What sequences would you want to see?
I'd like to see diffusion if it's there, and SWI also.
You would want to see an SWI. I have got a gradient echo sequence.
Okay, sir. Okay, here I can. Um, um, I'm suspecting a few, maybe a blooming foci over there.
Yeah, but you could see calcium on the
Yeah,
CT.
on
So
CT as well. Yeah.
okay, so for
Okay.
so
Probably they
for
are the ones that are blooming. Yes, sir.
okay, so for the audience, I will so far sum up as we progress in the case. So for the audience, there is a lesion in the obex of the fourth ventricle. The candidate one thinks that it is separate from the medulla and the cervical cord. He also thinks that it is separate from the cerebellum. And on the CT scan, we could see calcification in the lesion, and that's also substantiated on the gradient echo sequence. And now he is asking for the post contrast images. So here is the post contrast study, and this is your post contrast study.
So in the post-contrast images, I see that there is a mild heterogeneous enhancement of the lesion
Yeah,
on these images.
okay. So now we have we, as I said to you, we have said this is outside the brain parenchyma.
Yes,
The two
yes, sir.
things that we have to determine, is it in relation to the dura or is it in relation to outside the dura? So what do you think on looking at these images?
I believe it's not. So if I can see the post-contrast sagittal images, yes, sir.
Yeah, I've given you the post contrast sagittal images.
Um, on these sections, I don't see any obvious dural tail which is enhancing. So I believe that my first differential would be ependymoma in this case, and
Yeah, okay,
as the lesion showed few calcification as well, and seems to be in relation to the inferior portion of the fourth ventricle, and seems insinuating and further going into the foramen magnum and into the upper cervical canal region.
okay,
And less
okay,
likely a meningioma, because I can't see a proper enhancing dural tail, and the T2 signal was also not looking like that of meningioma to me, although
okay.
it had calcifications.
Okay, so let me sum up this study for the audience who were looking at it. This was a case that was presented to the hospital as a road traffic accident. Uh, on the CT scan shows a few ischemic changes in the brain parenchyma, but do keep in mind when we go towards the foramen magnum, we can see the fourth ventricle, but we do not see the CSF at foramen magnum. So here I see an iso attenuation to the brain parenchyma, a lesion which is got internal calcification and is displacing the cervicomedullary junction and is lying at the foramen magnum with effacement of the CSF at foramen magnum. So at this stage, this is a lesion. We can't determine whether it is in the brain parenchyma or it is in relation to the dura. Certainly, it is not extra dural in location. The reason being, I can see the dura and this tumor being inside the dural lining. So at this stage, I would ask for an MRI and I would ask for standard sequences first, a T1, a T2, and a flare and a diffusion weighted sequence, that is standard sequences. So on the T1 weighted sequence, and one of the sequence can be an orthogonal, so it's better to see orthogonal. So on the T1 weighted sequence, I can see the cervicomedullary junction being displaced. I can see a soft tissue mass which is lying posterior to the cervicomedullary junction. There is no relationship of it with the C1 posterior arch or with the posterior aspect of the occipital bone. I can't separate cerebellum versus this tumor, but the I can see the cerebellar folia on the sagittal images slightly separate from it. Its density is separate. And when I look at the T2 weighted sequence, I can see this lesion, which is iso iso signal to the cerebellum with some T2 signal change, but it is lying in the obex of the fourth ventricle and it has got no relationship to the cerebellum. It is displacing the vessels, the pica vessels, and the medulla anteriorly with edema of the medulla. Now, at this stage, I would be asking for contrast imaging, which we showed. So the contrast imaging shows heterogeneous enhancement of this lesion and there is no relationship of this lesion with the dura. So it is an extramedullary intradural lesion at the obex. So what is the differential diagnosis? What are the differential diagnosis of this lesion will the tumors will arise from the structures that lie in this area. So what are the structures in this area? The structure in this area is choroid plexus. The structure in this area is the vasculature. And the structure of this area is the dura. We determined that this is not in relation to the dura. You can see it separate. So it is not a dural based lesion. So it's not a meningioma. So now the debate is it a choroid plexus lesion, like a choroid plexus carcinoma, choroid plexus papilloma, or an ependymoma that also is in this structure. The other thing which you cannot rule out, though is less likely, is a meningioma. So these are a few things that you are going to think about. To do is what you need to do is you need to think on those lines. The other thing important here at this stage is you also need to see the neural axis. There are no drop lesions noted with ependymoma. You can have multiple ependymomas, and you can have this as a part of a whole neural axis series. So that's how you go about it. Have you got it right?
Yes, sir.
Okay. So let's go to our case number 2 so that I can show you the next case. Okay, so the next case is okay. So this is a case which has got the history is patient with progressive mobility uh, worsening, numbness initially to the feet, going to the waist, and now involving both hands. And that's the MRI. It's a brain and a cervical spine MRI, and the brain images.
Okay. Okay, sir.
You have to pick up some speed so that I can show you more cases.
Okay, sir. So I've been provided with axial sections, flare images of this patient who is having mobility issues progressively increasing from feet to the trunk region.
Yeah.
Uh, on these
Okay.
flare images, I don't see. So if you can change the window a bit, so that
Yeah, I can change the window. Can you? Is it okay with you?
yeah, yeah, yeah. So here,
Okay. Can you see anything?
no, I can't see much.
Okay. So if it is normal, then this is normal. So that you
Yeah,
don't see anything.
yeah.
It is a brain and a cervical spine study. So as I said to you, do you want to see anything else in the brain before I show you
Um,
the?
since I've already seen the flare images, I'd like to just take a look at the diffusion weighted images if they're
You want
there.
to see the diffusion weighted image? Okay. Here is the diffusion weighted image.
Yeah, they also don't see show any obvious acute restriction focus. So then I'd like to proceed with the cervical cord MR.
Okay. So here comes the cervical. So this is your T2. I'm going to change the window for you.
Okay, so I've been provided with T2 sagittal sections of the cervical spine, this patient, and I can see some hyperintensity, long segment T2 hyperintensity spanning the cervicodorsal cord, in fact, from the level of C2 vertebra till the upper dorsal levels. And with this, I like to correlate this with the axial T2 sections as well. Um,
Okay, so here comes the axial T2 section. I will mag it
yeah,
up for you.
okay, sir. So here again, I can see that the hyperintensity which I saw on the sagittal sections are also evident on the transverse sections also.
Yeah.
And it's mainly involving the posterior portion of the cord in the affected areas. Uh, so since
So
it's a long, furthermore, I would like to see the diffusion weighted images of the cervical cord as well if they're there.
no, there is no diffusion weighted image on the. What do you want to see in the diffusion? What is the purpose of you asking for a
Any
diffusion?
any just to rule out any ischemia.
Remember, the cervical cord is very heavily vascularized, both the vertebral artery supply and
Okay, sir.
ischemia of the cervical cord is not a common phenomenon, it's a rare phenomenon.
Okay, sir.
Okay.
Then stud images if they're there, but although I have
No, this is what you have. This is what you have.
okay.
So, what do you think now at this stage?
So at this with this long segment involvement, I believe that this could be a case of myelitis,
Okay.
uh, um, or could be due to subacute combined degeneration of the cord because these mainly involve the posterior portion of the cord. And I believe that MS is unlikely because the brain is spared and it's a long segment involvement of the cord. So I believe these two possibilities as differentials in this case, but I would like to correlate with the clinical overall clinical picture, the biochemical parameters to come to
Okay. Okay.
final
So,
diagnosis. Clinical
for
classification as
the
well.
audience, let me sum it up. Um, the brain sequences, flare and diffusion, we saw they were okay. There were no problems with it. Then we went to the cervical spine sequence and we saw, and this is the signal change in the cord. If you see, I've changed the window. and you can see there is signal change in the cord. You can see here it's in the posterior half of the cord, and if you can see here on the axial, as I scroll down, you can see the signal change is in the posterior columns, the dorsal columns, and this is a very long segment involvement involving right from the cervical down into the dorsal. So much of long segment is not usually that of transverse myelitis or ischemia, especially the dorsal side. The dorsal column involvement is that of a B12 deficiency, subacute degeneration of the cord, and this is a classical picture. It's a diagnostic picture. You don't need post contrast. You only need to get a B12 check. And you, if you look at the follow-ups, you will see that the follow-up, this has become even more prominent, because initially it was not treated, and when it got treated, you can see it is more going down to the thoracic spine. So well done. That is a good one. Excellent. You did a good job. So
Thank you, sir.
you wrapped it up very well. You were doing good on this. Okay, so let's do you another case before candidate number 2. Please keep an eye on the timings, that when his 40 minutes are done, then please let me know. We have to give him some margin because we started a bit late, so we have to give him a bit of margin. Okay, so this is a patient who came to us with unwitnessed fall, loss of consciousness, bilateral, I'm reading exact history, bilateral orbital bruising, nasal query fracture, hypertensive, low heart rate, rule out intracranial complications. So I'm going to start from the top.
Okay, sir. So I've been provided with non-contrast CT sections, axial sections of this patient, and I can see that there are prominent ventricular system as well as the sulci, and besides that, I can see that there is pronounced hypodensity of the periventricular white matter as well as the white matter in the centrum semiovale, and some besides hypodensity was also seen along the capsule region
Okay,
bilaterally.
okay,
So, and sir, if you can come down.
okay, I can,
Yeah,
yeah. Good, you have
in the
started to
basal
look at foramen magnum.
sections, yeah, in the basal sections, I don't see any significant finding in the brainstem area and in the
Okay,
orbits. So,
okay, carry
yeah,
on, yeah.
but there's definitely pronounced hypodensity in the white matter area regions, yeah, in this patient.
Okay, so how would you sum this up?
Um, so this finding could be incidental in nature and not related to the trauma which the patient has sustained. So I believe that this could be related to the chronic hypertensive status of the patient.
Okay,
And I would like to further negotiate this with the MR scan if they are
okay, what
there.
do you want to see in the MR?
I'd like to look at the flare images, T2 and flare images.
Okay, so so for the audience, let me sum up this case on your behalf. You see Physicus 3 scale confluent white matter small vessel ischemic changes. You see some ischemic changes in the basal ganglia. You see some ischemic changes in the thalami, maybe some small ischemic changes in the pontine region with generalized involutional changes. Very, very important in this case is there are which examiner wants to hear is, are there any brain contusions? That's number one. Is there any intraventricular hemorrhage? Is there interpeduncular cistern hemorrhage? Is there
No,
any
no.
hemorrhage along the basal, along the foramen magnum layered? So these are the things examiner wants to hear. And is there any traumatic subarachnoid hemorrhage or subtle subdural or extradural hemorrhages? Those are the things that examiner wants to hear, which were important. The other thing which I would have wanted candidate number one to say,
Yes, sir.
remember this is an fall and a trauma type situation. I would
Yes, sir.
have wanted you to comment on high density of the fox, but at the same time, I would have wanted you to say this is because of the heavy calcification, because
Occasions.
so these are the things
Okay,
examiner
sir.
wants to hear. And then
Okay, sir.
also here along the tentorium, this is have high density of the tentorium with some calcification. So
Yes, sir.
this tells the examiner that you have seen the high density, but you have ruled it out that this is not real. It is because of the calcification. Now, the very
Okay, sir.
important thing which I expected you to do, which you did not ask, so I did not give you, was you did not ask me to look at show you the bone window.
On
So
window, yes, sir.
now I'm going to show you the bone window. So have a look at the bone window. Very, very important in exam to show the bone window. That is, or at least ask the examiner, I want to see the bone window. Especially this is a trauma situation. Okay,
Okay, sir.
over to you.
So
Here you go.
I'm going through the bone window axial sections of this patient, but I'm going from the vertex downwards, and till now I've not been able to see any fractures. Uh,
Yeah, keep going. Keep talking.
yeah, I am now looking at the basal sections, and I don't see any obvious fractures till now. Yes,
So coming up now from the
yeah,
bottom, coming up again.
yeah, and again I can't see any obvious fractures. The temporomandibular joints also look normal. The orbital areas also look normal to me. No obvious fractures which I can see.
Now, here is something for the general audience. When you look at the bones in exam, remember you have to keep the examiner engaged. So if I was looking at this CT scan, I would on way going down, whether I want to see the front or the back, I would say I'm looking at the front of the calvarium, and I'm looking at the frontal bones, and I'm looking at the part of the temporal bones, but at the front of the calvarium, I'm looking at the frontal sinuses. I'm looking at the orbits. They look normal. I'm looking at the sinuses. So you are telling the examiner what you are looking at, because examiner does not know what your heart is thinking, or your brain
Yes.
is kind of thinking how you're going. So then I would say I'm looking at the front, the ethmoid and sphenoid sinuses. So I'm just concentrating in the front half of the calvarium. So I'll
Yes.
say here I can see movement artifact of the nasal bones. I can't figure out there is a fracture or not. I can see there is significant soft tissue swelling. Because of movement artifact, I don't know there is a fracture or not, but I can see there is no blood in the maxillary sinuses. So this comes why, and then I've reached this. Then I say I'm now looking at the mandible, the part of the temporomandibular joints. They look okay. Zygomatic arches are okay. I'm looking at the squamous temporal bone. So you are coming up on the middle part of the brain. So you have seen this, you describe, keep coming, and then I say I'm going down on the occipital part of the calvarium. There is nothing in the occipital bone, nothing in the petrous temporal bone, etc., etc. And then I stop here. What do you see here? What is this? What is this? And which bone it is? So this is the C1 ring. This is the dens, which shows degenerative changes. You saw this patient is an old patient, but this is not normal. There is no suture in the C1 arch. So what is this?
Um, Fracture
So
of
this is a
the
fracture. So
yes.
is this an acute fracture or a non-acute fracture?
Uh, this seems to be doesn't seem to be acute because there's some sclerosis also which I can see.
Correct. So you say that I can see a fracture, but there is some sclerosis around. So this does not appear a non-acute fracture. So, and then the C2 is unremarkable. However, I don't see the full detail of it. I would want to have the sagittal images if I can have. So then they will show you the sagittal image. So look at this. What does it show?
Um,
Which bone is it?
this is odontoid process.
This is the base of the dens. So you can see a
Yes, sir. So
fracture going through and through.
yes, sir.
So at this stage, you will say this does not look acute, degenerative changes. What would you do further?
I'd like to go for MR scan to see the status
No,
of the
you
cord.
would want to see the CT scan of the cervical spine, and then you would ask for an MR. Remember, MR is to look at the bone edema and ligamentous injury. You
Yes,
would
sir.
see the bones with the CT scan. This is an old patient, and on table, you would want to, and getting a CT scan is much easier. So you would
Okay.
want to have a CT look of the cervical spine, and then depending on what you see, you would ask for an MRI because this
Okay.
fracture does not look acute.
Yes.
Yeah.
Okay,
So
sir.
these are important things. So you go through a system, front of the bones, middle of the bones, back of the bones, you or vice versa, whichever way you want. But do not um, miss the base of the skull because that's where you miss major fractures.
Okay, sir. Thank you.
Yeah. Okay.
Okay, sir.
So
Thank
how
you, sir.
much time are we? Are we 40 minutes done with you, or what is the situation? Okay. Candidate number 2, are you keeping an eye on things? We started. I can show you one more case, in fact, and then I can move on to candidate number 2. Let me show you another case. Okay, so this is a patient which has a clinical history of, let me show you, clinical history of uh, upgoing planters and weakness and eversion of the foot.
Okay, sir. So, so these are T1
Yeah,
and T2 separated
yeah,
uh, of this patient. Um, so here I can, on the T1 weighted images, I can see that there is a, so if you can just scroll, yes.
yeah.
Yeah, here I can see that there is a small, possibly a small lesion there in the upper portion of the cervical cord at the C3, sorry, C4 vertebral level with a tiny T1 hyperintense focus within it. So I would like to further correlate this with the T2 sagittal weighted images. If
Okay, so here is your T2. I'm going to mag this up. Okay, so
So here on these T2 weighted images, I can see that there is some expansion of the cord at this level, and there is a lesion in the cord at this level, which I mentioned on the T1 weighted images, and it's appearing mildly hyperintense in the central portion with surrounding T2 hypointensity. I would like to further see this on the axial images if they are available.
okay, I can show you the axial images. Okay, so which axial image you want to see first?
Um, T1 as well as T2.
T1. Okay, so let me just Okay, so here you are, T1 and T2. So I'm scrolling through. Can you see okay, or should I mag it up more?
Um, no, I can see.
There you go.
Uh, okay. So I can see that the lesion seems to be eccentrically placed
Yeah.
towards the left side on the axial sections on these T1 weighted images, um, and I would like to see this on the T2 weighted images also, if possible. Okay. So again, as we saw on the sagittal weighted images, again it's markedly hypointense with central hyperintensity on the T2 weighted images. I'd like to further see this on the gradient if they are available.
This is the gradient echo T2.
Okay, so it's further. I would like to see the contrast images.
Uh, Contrast images were not considered necessary here.
Okay, so
But yeah, good. But why do you want to give contrast? What is in your mind that you think is necessary?
uh, just to further characterize um
Okay,
whether
here is your
it's
contrast.
required.
Here is your contrast images.
Okay, so on the contrast images, I think there's a mild enhancement within the lesion. So the lesion seems to be extramedullary intradural in location to me, seeing the axial images, and seems to be displacing the cord towards the right side. So
Okay, so how would you sum it up? Okay, so far let me sum it up for you. There is
okay,
an extramedullary intradural lesion at C4
for
level, um, which shows T1 bright signal, T2 low signal, speckled, faint enhancement, in fact, borderline enhancement, which may or may not be there. But anyway, so you have given me the description so far, but you have not given me the differential diagnosis of this lesion.
yeah, um, in the differential diagnosis, this could be this could be a small um, um, this could be a small cavernoma, because there is marked hypointense rim on T2 weighted images, which I can see, and with the which was appeared more pronounced on the gradient. Uh,
So
yes, on the
how
gradient side.
how is a cavernoma be? You have said
Extramedullary, yes.
extramedullary intradural. It won't be in the thin air. It
Yes.
has to be into a parenchyma.
So, but it doesn't fit into any of the extramedullary intradural tumors as well. So, uh,
Okay, so let me wrap it up for you. Okay,
okay, so
so it is a lesion which is low T1, marginal central T1 high signal. It has got a hemosiderin low signal with a bright T2. It has got a bright T2 center with a complete hemosiderin rim. It is occupying the left half of the cervical cord at C4 level. It doesn't show any avid enhancement. Given hemosiderin deposition, central non dark T2 signal, this has got features of a cavernous venous malformation. So this is a cavernous diagnostic cavernous venous malformation imaging. The reason why? Because the chemosiderin rim is complete and there is a central mulberry of bleed that usually cavernomas have. Cavernomas
Yes.
always have a central, because it bleeds in the center and it throws the hemosiderin to the periphery. So that's why it has a complete rim. So you
Yes.
can have cavernomas in the cervical cord. You can have one, you can have multiple. So the other common usual thing that happens is people also tend to do brain some sequences to see is it part of the cavernomatosis or is it a single lesion. If it is more than two cavernomas in the brain or brain and cord, then they send them for genetics. Okay, so
Okay,
what
sir.
is the treatment? Because in exam it is actually you are a clinical radiologist. So in the treatment, if there is, this is a difficult area to biopsy, but if it is increasing in size and repeatedly bleeding and patient getting clinically worse, then the surgeons operate. Otherwise, they just watch and wait. Okay,
Okay, sir. Okay, sir.
perfect, excellent. Okay, so now candidate number two, please. Candidate number two, are you there? So tell me, please, when you are ready.
Candidate two, can you, uh, candidate two, we cannot hear you.
You hear me?
Say again, please.
Sir, can you hear me?
Now we can hear you. Dr. Jazoon, over to you.
Yeah, okay, thank you so much. Okay, so this is a patient which has come to our hospital with a right-sided weakness, sudden onset, and that's the CT scan that has been done. So I am going to go, oh sorry, I'm going to go from the base up for you. So please tell me when to stop or do the start the description.
Sir, can you please go from the vertex to the downward?
Vertex, okay, no problem. Yeah, I'm at the vertex, so I am going down.
Sir, in the left frontal lobe, I can see a hyperdense lesion. Uh, Please go to the vertex, sir.
Yeah.
So, yeah, it's in the fox. Probably it's a calcification in the fox cerebri. I cannot appreciate any significant abnormality as we are going downwards, except calcifications of the choroid. Again, there are calcifications likely of the cerebral fox.
Okay. Keep going. Keep going. You don't. There shouldn't be silence. Keep describing as I show the images.
Oh, okay, sir. Okay, sir. There are. I can appreciate that there are diffuse hyperdensities in the left cerebral region. I can also appreciate that so there is no parenchymal abnormality on the CT scan in these images. But at this point, please stop here. I can see on the left frontal region, I can see a ill-defined hypodensity, which is in confluent with the centrum semi-ovale. This hypodensity is ill-defined and seems to be irregular to me. And can we scroll downwards, please?
Yeah.
Yeah, it's extending downwards, and it appears ill-defined. I would like to see any Here, please stop here, sir. Some upward, more upward. Yeah, here I can see in the left there is a hyperdensity. There is a center. There is a dot hyperdense area. Please some upward.
Yeah, I can show.
Yeah, there is the yeah. Uh,
Yeah,
few
carry
slices
on.
below, few slices below, sir. Yeah, here stop, please. So in the left cerebral hemisphere, in the region of the lateral to the basal ganglia and the region of the insular cortex, I can appreciate that there is a central dot type hyperdensity which is not on the right side. So it can be a blood vessel in which there is a
So
thrombus.
how would you sum up this CT? Because
Uh,
you've done the description. So now remember, in exam, if you prolong your description too much, you are losing time on one study. So if you are confident that you have got the description right and you have got the pathology, you need to wrap it up. So what is so
Uh, so,
so that I can wrap it up for the audience, what you described so far. You think there is a dense M2 segment. It is called M2 dot sign. This is the dense M2, and then you think this is gyral hyper loss of gray white matter differentiation in the suprasylvian left frontal lobe reaching the vertex. Most important thing that I would have expected that you would ask me for a stroke window. So this is the stroke window. You can see you can see all these findings becoming pronounced. So you can see loss of gray white matter differentiation, frontal parenchymal changes, and a bit of insular cortex changes. The most important thing the clinician and the examiner wants to hear, is there any contraindication to treatment? Whether there is any hemorrhage, whether there is anything that has got a contraindication to treatment. So what are the treatments you would tell the examiner that you know of?
Sir, I would like to request the cerebral angiography, CT cerebral angiography of this patient, just to be sure that the size of the this thrombus and the extent of the thrombus. Then I can advise the carotid Doppler of this patient to see its extent into the IC and the common carotid. And next, if there is a thrombus, I would advise that there should be thrombolysis of this patient depending upon the time window from when the symptoms start, and we shift if these are within the 6 hours, then we shift the patient to the angiography suite and advise a conventional catheter angiography, and then give the drugs like thrombolytic agents like altapase and to diffuse this thrombus and relieve the patient symptoms.
Okay, so yeah, that's correct. So all these things should come side by side to your description so that the examiner knows that you know the clinical side. Okay, so I am going to show you the CT angiogram. So I am coming from the base up. Do you want me to go from the base up or the
Yes,
vertex
sir.
down?
Yes, sir. Sure, sir. From the
So
base.
this is, yeah. So now keep describing so that the all the audience also know what you are talking about.
Sir,
So what are you going to first thing? Before we start, what are you going to look at? What tree structure you are going to look at?
so my interest would be the common carotid artery and then the internal carotid
Which
artery.
side?
Sir,
Which,
on the left side.
okay, so let's concentrate on the left carotid. So keep looking and keep describing.
Yes, it is normally opacified with contrast, and at this level. So, sir, please, slow,
Yeah,
backward,
yeah, yeah.
backward, 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 backward. Yes, please upward, please.
Okay. So what do you see so far? Keep describing so that the
Uh,
audience and myself know that what you're looking at.
Sir, I am looking at the common carotid artery, and it is bifurcating into the external carotid and the internal carotid, and then I can see the internal carotid artery. It's entering into the brain, and inside the brain, it's dividing into the MCA and the ACA, and then uh, uh, I can appreciate, sir, just below where it is dividing into the MCA and the ACA. I would like to see the
Okay,
junction.
so yeah, this is the junction.
Uh, uh, I can see that the MCA, the second part of the MCA, M2 segment is not properly visualized when we compare it with the right side. It's a thrombus in that component, M2 component of the left internal carotid artery, and then further we would go for the catheter angiography to thrombolyze this thrombus.
Yeah, okay. So for the candidates, let me sum up what you were saying. You were saying that the carotid is normal, and you can see a thrombus in the M2 segment, and you would go for catheter angiography. Am I correct?
Yes, sir. We would go for the catheter angiography only if we wish to continue for the thrombolysis, and it would depend when the symptoms of the patient start. If it's out of the window, then I think the catheter angiography would not be more useful to us. So it depends upon the clinical decision. If it's within the 6 hours, then we would immediately go for the catheter angiography and would try to thrombolyze this thrombus.
Okay. Okay. So here is what I would be looking at. So here I start. The first thing that I look on a CT angiogram is the aortic arch, because you can have an aortic arch dissection. That's important. I also look at the pulmonary veins, because you can off and on see a pulmonary vein thrombus as well. And then I start looking at so in this case, we are looking at the left carotid, and that's the vessel I would look first. So left carotid I'm looking. This is the common I'm looking. Then I'm looking at the carotid bifurcation, that there is no ulcerating plaque or stenosis. And then I would start going into the internal carotid and keep watching the internal carotid as it takes a circular bend, which is a normal anatomy. But what is this? I can see there is a filling defect here in the vessel, and then it takes a turn. And so there is a filling defect, there is narrowing, and then it takes another turn. And then it has got a bit of a reduced caliber. The good thing is you should compare always the vessel to the contralateral side. So here you see its caliber is gone. So you got a thrombus, a turn. Always look at the curved part of the vessels clearly, because that's the common site of the dissections. So here you can see a thrombus, narrowing, and a dissection flap. And the flap has given a thrombus. Then I come up, I see cavernous carotid, paraclinoid, and then you see the T junction of the MCA ACA. That looks okay. And then when you go up, you can see here the vessel is visible, but the other vessel, which is this one, then it fades out. You don't see it. So that's where the thrombus was, M2 we saw. And this is the other branch that comes up. So that's the branch that you saw was missing. So you could see coming up, and then it got missed. So when you thicken the slab of the angiogram, you see there is a branch that got missed. There is one branch coming. And the other thing that is important is that when you see, compare the two sides, look at here, you see some missing of the vessels in comparison to the right side. Always look at the right side, and then you see that there in this area the vessels are missing. And then you further look at the rest of the vasculature as it is. So here is something, a concept I will clear. The IV TPA, the thrombolysis, is still within 6 hours. But remember, the trials, the latest current trials have shown that the large vessel occlusion, that is the ICA, MCA, ACA, the large vessels, the big thrombus load does not get dissolved with the TPA IV thrombolysis. So they have to be taken out through the catheter angiogram. And for them, there is no time bar now. The only time bar is how is the aspect score. So you need to know the aspect score that is now prevalent. So let me show you the aspect score of this patient. So see, the aspect score is comprised of chordate nucleus, lentiform nucleus, insular cortex, M1, M2, M1, M2, M3, M4, M5, M6. So this all becomes 10. So this is the artificial intelligence. So the 10, any area that gets involved is subtracted from it. So if you see 3 areas involved, so this will become aspect score. 10 minus 3 is 7. So in this case, 2 areas, the artificial intelligence thought that 2 areas are involved. So it is an aspect score of 8. So now if aspect score 6 and above, you go for thrombectomy. There is no contraindication to thrombectomy. So IVTPA is 6 hours, but the aspect score of 6 and above is no contraindication to thrombectomy. So in this case, what we did was we went for a catheter angiogram and we looked at, that's your dissection flap. You can see the filling defect and that you can see the narrowing. So this is the dissection flap. And then we were looking for the thrombus. You can see here, let me show you. Here you can see there is no, the branch is missing. This is retrograde filling of the M2 branches. So this is the PL retrograde filling. So all this area has got a capillary supply. This area has got a capillary supply. There is no capillary supply here. So that's where this branch is occluded. And if you can see here, see this is contrastasis. So the narrowing here is, they call it the meniscus sign. It's like a meniscus. So there is M2 is, distal M2 is occluded. That's where the thrombus is. So we went in and we took out the clot from this area, and that's now the, and at the end, so this is opened up. You can see the branch has come back in comparison to the other side, to the pre-procedure. So you can see. Okay, so you got this right?
Okay, sir.
Okay,
Thank
so
you, sir.
let us see this. No problem. So let us go through another case. Okay, so this operating cognition, persistent right-sided epileptic fits, and being investigated for acute worsening cognition.
Right, sir.
Okay, so I have given you a flare and a post-contrast directly.
Okay, sir.
So you wanted me to come from your mind is oriented from the vertex. So I'm showing you from the vertex down images.
Okay, sir. Sir, in these, sir, the below image
Is
is
a
that
post-contrast.
just
T1
contrast one?
post-contrast, fat-satted images or
Okay.
images post-contrast. We always do fat-satted so that any fat does not mess up with the post-contrast. So you, anything bright is like a either a vessel or enhancement.
Right, sir. Sir, please start from the vertex slowly.
Vertex, okay.
Explain.
So let's go through this first, layer first.
Sir, in these images, I can appreciate that on the right side there is a signal.
Right side is you're talking this side where
Yes,
my
sir.
arrow
Yes,
is.
sir.
Okay.
Just upward. Yes, this area on the right side in the centrum semi-ovale region in the subcortical white matter. I can appreciate that there is a hyper intense foci, ill-defined foci. Uh, this ill-defined foci, I would like to see the downward images if there are any other such foci.
Yeah.
Uh, I am unable to appreciate any other hyperintense foci in rest of the brain parenchyma. So I would suspect that this single hyperintense foci could be due to an old ischemic demyelination due to any microvascular injury to the brain in this region. There is an artifact, sir, below. Uh,
Remember, there is a bit of a movement artifact.
yes,
You can see a bit of a
yes,
lines
sir,
going
there is
across.
a
So,
movement
yeah.
artifact in this region, and the basal ganglia are okay. There is no periventricular signal abnormality. Uh, yes, that's good, sir.
What do you see now?
S-
What is the difference you see now between the two hemispheres?
sir, I can. Uh, I can appreciate on the right side. On the right side, there is the cortex. The cortex of the frontal lobe is somewhat distorted in signal, altered signals as compared as
Are
we
you
compare.
talking right side is the patient right side? Remember, this is the left side of the patient. This is the right side of the patient. So which
Yes,
side are you talking? This
sir, on
side?
the right side. Sir, on the right side of the image. On the right
Okay,
side of
so
the patient.
the patient right side is this. Remember,
Yes,
this is left
yes,
side.
yes, sir. I am talking
So,
about patient side. On the right side of the patient.
okay, so where my arrow is. Okay, so there I'll keep the arrow on the right side of the patient.
Yes.
Okay, keep going.
I can appreciate that the cortex is some altered signals in the cortex of this patient. Uh, mm,
Okay, so you see, okay, so let me sum this up. Um, for you, you can see some altered signal in the frontal lobe of the patient on the right side. You can see an old infarct, suspected old infarct in the right deep white matter, and that's what your description was. And what about post contrast? Do you see anything in the post contrast?
sir, on the abnormal T2 areas, flare areas, I can't appreciate any signal abnormality on the T1 post contrast images. Uh, s- uh,
Okay, so what do you see so far?
uh, Sir, I cannot appreciate any significant abnormality on the T1 post contrast images in the, but I would like to focus on the posterior fossa on the T1 post contrast. Mm.
Yeah,
The,
what do you
cere-
see?
the cerebellar hemispheres are normal, the vermis is normal, the pons is normal. Uh, uh,
Okay, so let me take you back to the flare sequence. Do you see any? Now I've changed the window, and do you see anything?
sir, on the right side of the patient, there is a decrease in volume of the cerebral cortex of the patient in the frontal region, and it corresponds with the history of decrease in cognition of the patient as you described. So there is a decrease in the volume of the cerebral cortex in the frontal region. I would suspect, I would look for the reasons why there is a decrease in the volume of the cerebral
What are you
cortex.
suspecting? What is your differential diagnosis for that?
My first differential diagnosis would be it can be an AV malformation like Sturge-Weber syndrome, which can cause the cerebral hypertrophy. That would be my top differential. Other differentials, it can be um, uh, it can be the most likely there is a decrease in blood flow on the cerebral cortex, due to which it has hypertrophied, and this decrease in
Okay,
blood flow most
no
likely.
problem. So, okay, what do you see on this study? This is a diffusion weighted sequence I have shown you. What do you see? What is this? Why is this cortex so bright in comparison to the other side? Look at this cortex, this area, caudate nucleus, this including bilateral occipital, cortical area, they are very bright. Why? There is a rapid decline in cognition.
Sir, this decrease in this diffusion restriction of the cerebral cortex specifically determines that there is a decrease in blood supply of the cortex, because the cortex is highly susceptible to brain ischemia. Even the slight changes.
Ischemia, remember, ischemia has got a very classical history.
Uh, So this diffusion restriction specifically in the cerebral cortex, I can't think of any other cause except that this restriction in diffusion in the cerebral cortex, that is highly susceptible area to the even slight changes in the brain blood flow dynamics. So there should be a difference. There should be. Uh,
There is
Really, I
another
would like to see
condition.
the ADC images, if there
There
is
is
ADC images available.
there is another condition that gives you this type of a bright with this classical history of an epileptic fit, rapid decline in cognition with cortical diffusion change like this. This is a classical pattern for a sporadic CJD.
Oh, right, sir.
So always remember this territory. It is being any lateral vertex. The pulvinar sign is the medial thalamus that gives but the sporadic variety gives you diffusion high signal, and I showed you the flare high signal too that it gives. So I changed the window for you. This is the change window. So look at this. Does not obey any classical pattern. It has got a classical history, imaging pattern.
Right, sir.
Okay. The reason why it is very important to diagnose this, the clinical significance of this is that if this patient is going for any operation or anything, they have to quarantine all the equipment. So it is a vital and a crucial diagnosis. Luckily, it has got quite a diagnostic history and quite a diagnostic appearances.
Right, sir.
Okay, good.
Yes, sir.
Excellent. Let's see another case. Okay, so this is a patient who was referred for back pain, profoundly myelopathic, and they wanted an urgent spine MRI. It came from the spinal surgical team, and there is a whole spine MR. So I'll show you the lumbar first.
Sir, can I see the T1, T2, and star on the same screen simultaneously?
You want to see the T1, T2 on the screen. Okay.
And
T1 and the stir.
So T2 star.
On the right side this is the T2 stir. This one. This is T2 stir. And this one is your T1. Okay.
Right, sir.
Okay. So I'll go from one side. I'm starting from the left to the right. Remember, we've got a whole spine MR on this.
Sir, can you please magnify only the T2 stir sequence for me?
Yeah. Okay. So I am starting from right back to the left.
Right, sir.
Okay. So keep talking so that everybody knows what you.
In this T2 star images, I can appreciate that the spinal cord in the lumbosacral region appears normal to me. Sir, I would like to see the axial sections.
Okay, the axial sections. There you go.
So can we scroll it side by side?
Yes, we can. Here you go.
Sir, from the top to the bottom, please.
Okay, so this is the axial that we have available on this study.
Sir,
so what are you looking for?
Sir, I am looking at the cord and the chorda equina. I was suspecting.
Okay, so cord and the chorda equina. Here is your cord. Okay, here is your cord, lower thoracic cord, conus.
It appears to be normal, but in the yes, in the sir, in the center. Yes, here, sir, I am suspecting here that there is a tethered. I have a suspicion of tethered cord, and the chorda equina is going downwards. So, can you please magnify the axial section to me?
Yeah, I can. Yeah, here you go. So when do you say tethered cord? Well, what should be the level of the conus with the tethered cord?
So the conus should be the conus should be below at the level of L5 and L4. When we say it's a normally it should end up at the L1 and L2 level, but when it's go downward, then we say it's tethered.
L5 would be here. L5 would be here.
Yes.
L3 and below, we call it tethered cord.
Yes, below. Ideally, it should be at the level of 1 and 2, and when it go downward, we say it's a tethered cord. And to me, it appears to be it's a tethered cord.
Why do you say it is tethered cord when the conus is at 5, 4, 3, 2, 1, L1? This is where your conus is lying. So why do you say this is a tethered cord?
I'm suspecting there are the fibers of the chorda equina are abnormally thickened. I was suspecting it can be the cord. These thickened chorda equina fibers, thickened chorda equina fibers can be due to other reasons as well. Other reasons like inflammatory, and due to inflammation, these fibers can be thickened. so it can give a false appearance that the conus is going downward. So you're right that the conus is above at the level of L1 and L2, but the cordycoina fibers are somewhat thickened and more thickened than the normal. And most likely, this thickness of the cordycoina fibers related to the inflammatory cause. I cannot appreciate any significant mass lesion. However, I would like to see the post contrast images if available at the level of cordycoina.
There are first and foremost. Okay, so let me just sum it up because for the audience. So you think first you thought that the conus is way down to L5, which is not the case. The conus is at T12, L1 level. The second thing you thought was the phylum nerve roots are thickened. They are always, if you look at here, this is a very normal phylum nerve root. And then when you look at the axials, there is nothing wrong. There is no cord thickening or clumping, arachnoiditis. So all this is normal. So there is nothing wrong with it. The more other important thing which you got digressed because you concentrated was this, that this is a small lesion in the phylum nerve root, so this is most likely a small schwannoma. The other important thing is L5S1. You look at the L5S1, you have got a degenerative stir-eye signal, space reduction, modic 1 end plate degenerative change. Here, you suspect that there is a pars defect with exit foraminal compromise, and you can see there is a sclerosis here. You suspect there is a pars defect with mild degenerative anteriorly ceases L5 over S1 vertebra. So, but I told you that this patient has got a whole spine MR. So, would you want to see the thoracic and other areas?
Yes, sir. Sure, sir.
Okay, so
Thoracic.
here is the
Yes.
this is the thoracic spine. So I am going to scroll them together for you. So we are going from left to right.
Sir, I can appreciate that in the lower cervical and upper thoracic region. Sir, please stop at the center. There is a lesion in the cord. Uh, so at this level, in the upper thoracic and the lower cervical vertebra, I can appreciate that there is an altered signal intensity, ill-defined area, which is extending from top a long segment area comprising almost five vertebral levels, per thoracic and the lower cervical. This area is involving the
That we have to remember whether whether it is intramedullary, whether it is intradural, extramedullary, extradural, or arising from the bone.
sir, can we please magnify only this lesion?
Okay, so this lesion is magnified. So is it arising from the bone?
No, sir, it's not arising
Okay,
from the bone. It's an
so
extramedullary lesion and
okay.
intradural extramedullary lesion.
So
Uh,
where do you think the dural lining is so that the everyone is clear about it? Is this black line the dural lining or is this the dural lining?
Sir, I think that black lining is
This
the.
one where my arrow is.
Yes, sir, I think it is.
Okay, so then in that case, this is an extradural lesion
Oh, yes, sir.
because because it is extra outside the dura. Dura is pushed inside, it is extra. Am I correct?
Yes, sir. Yes, sir.
Okay, so
It's an extradural lesion, and which is hypointense on T2 weighted images, and also hypointense on the T1 weighted images. I would like to see any post contrast enhancement of this lesion.
okay, so you would want to see post contrast images. Let me just see if I can fish out some post contrast imaging for you. Okay, so that's the post contrast image.
So there is, yes, there is the lesion is significantly homogeneously enhancing on the post contrast images, and it is compressing the cord towards the interior side. This is a smooth margins lesion which is homogeneously enhancing. It is extradural. I would like to see on axial images if there is. Uh, I can also appreciate that there is some dural tail on these post contrast images. My differentials for this lesion, it can be rising from the dura. It can be a meningioma. I would confirm.
Remember, the meningiomas um, go usually inside. They are in the dura, extramedullary intradural. What are the other things that commonly arise here? Could it be an abscess?
Sir, no, because it's enhancing. If it is abscess,
Okay.
if it is
What
abscess,
other thing usually is here like this?
homogeneously enhancing
Yeah,
extradural long segment lesion in the upper thoracic region, which is not distorting. Sir, I would like to see the bones. It is causing any destruction of the bones of the vertebra.
it is not causing any bone destruction. You can
So
see here
it's
the
a
bones are,
non-aggressive. Sir, it's a non-aggressive
yes.
lesion. It
Okay.
it doesn't appear to be malignant, so it's a benign lesion which is homogeneously enhancing. Uh,
The
uh,
other lesion that arise like this, long segment, extradural, solid, that are lymphomas. The lymphoma is a common identity that usually presents like this. It is extradural, does not behave boundaries, and is occupying this area in the epidural space. That's the common site for lymphomas that you should think of. The common two extradural long things that you commonly in your day-to-day practice is either an epidural abscess, which you ruled out because it is solid, and the other thing that is important to remember is a lymphoma. Those are the two common things that arise like this.
yes,
Okay,
sir. Yes,
good.
sir.
And the other very important thing that we did not, you did not mention, was a cord edema that this patient has got, which was visible on the previous images T2 that I was showing. Say here is the T2. So if you see, there is
Yes,
significant compression of the cord and thoracic cord edema.
right, sir.
Okay, those are important things. Okay, the
Sir, what's the
lo-
further management? How we will?
straight spinal surgeon.
Okay, thank you, sir.
There is a straight, and how urgent? Very urgent. This is not the one that you will notify through email or anything. This is because there is significant cord compression, there is cord edema, and it is a tumor. You would pick up the phone and you would talk to the spinal surgeons yourself.
Sir, can
This
we
is
refer
not
the patient to the radiation oncology for radiation to
but
deep?
that's up to the spinal surgical team, whether they usually these cases come to where there is an on-call oncologist. So there is a mini discussion between the spinal surgeon and the oncologist to determine which is the best mode of treatment for this patient. Treatment options lie with the spinal surgeon, not with yourself. Our job is to make sure the primary clinician who referred this patient knows that there is a tumor, there is cord edema, there is cord compression, and that's our job to notify them.
Right, sir. Thank you, sir.
Okay, that's the important bit. Okay, so next one is
We have to go to
okay.
the next candidate.
Okay, no problem.
Candidate 3, are you with us?
Yes, sir.
Okay,
Okay, over to
excellent.
Dr. Jadoon.
No problem.
Thank
Thank
you.
you, Dr. Sami. Okay, so let me show you. Okay. Okay, so this is a patient who presents to us to the hospital with a left-sided weakness, slurred speech, and gets a CT scan. But the CT scan does not show much. I will show you the CT scan for your just for your baseline,
Okay.
and then because on the CT scan nothing much was visible and the clinical history was strong, they referred straight this to the MRI. So I am going to show you both the CT and the MR for your comparison purposes. So here is the MR. I'm giving you the flare sequence. Do you want me to magnify the MR or do you want me to keep it going like this?
Can you please magnify it a little?
Yes, I can. No problem. Here you go. So I'm coming from the vertex down.
Okay, I'm presented with axial flare MRI of the brain. There are a few scattered white matter hyperintense foci in subcortical and preventricular areas.
Yeah, keep
I'm
going.
going
Keep speaking.
Okay.
And
Can
coming
we
up.
go back up again? Yeah, please. The cerebellum looks fine. Okay, can we go down a little bit again, please? The left, okay. More down. I'm suspecting like slightly hyperintense left transverse sinus, but I would like to see it on T2 to ascertain the flow void is preserved or not. And there is such.
Okay, I will show you the T2 as you have asked for. Yes.
Okay, going back on.
Yeah, keep speaking.
Yeah, the flow void of the left transverse sinus is lost, I think. And but other dural sinuses seem okay.
Yeah. Do you want to see a
Can I see the T1?
T1 in our stroke protocol, because there was
No.
a history of stroke, we don't do a T1.
Can I see diffusion and ADC? DWI.
I can. So before we go to diffusion, what do you think so far?
Well, I'm concerned about venous sinus thrombosis. On
Okay.
flare, can we go down to the pons more? Okay, on flare, I suspected a hyper-intense signal at the right hemipons, but it doesn't seem to be the, oh, there, yeah. At the right
Okay.
hemipons, it might be like old ischemic insult. I would ascertain from the DWI as well,
Mm-hmm.
if it is restricting or not. No associated mass effect. Other
Okay.
flow voids seem to be, major flow voids seem to be preserved.
Mm-hmm. So, can you, so for the audience, she thinks there is something in the venous sinus. She's not sure, but she is comfortable enough that there is nothing in the venous sinus. Then she is worried a bit about the pontine, but she is not very concerned. And in a stroke type situation, she thinks all the vessels are unremarkable. Am I correct? Have I summed you up appropriately?
Yes.
Okay. So then she is looking at what are you interested in now? What
DWI.
sequence? DWI. So here is your vertex. This
Okay.
is your DWI.
So far, no restricted diffusion. Okay, there's, I think, well, there's some hyperintensity at the right hemipons. In my routine practice, I would check the ADC to make sure it is not T to shine through, but I think it is restricted diffusion. Okay.
Not much. Okay. Maybe, maybe not.
Yeah.
Nothing very obvious.
Yes.
Okay.
No corresponding ADC hypointensity.
Yeah.
Okay. No other areas of restricted diffusion. And
So what is the thing that is missing in your description, in your observation? What is it? You looked at the vena. Okay, so let me sum it up for you.
okay.
So you did look at the white matter hyperintensities. You looked at the venous sinuses, but you, even on the T2 weighted sequence, you can see vessels being abnormal. Remember, the vessels have got flowing blood, they have got flow void. So if you look at the vessels closely, you can see both the ACAs, two parallel lines, they are okay. You can see the M1, you can see the A1 and ICA on both sides. You can see the flow void. You can see the basilar artery. You can see, and then you can see the carotids at the skull base. So far, so good. Am I correct?
Yeah.
Okay, you can see the basilar, then leftward. Where is the signal
The
in the
right.
rightward?
Yeah.
So there is no signal in the right vertebral artery. You can
Yes.
see parallel lines, but you don't see
That's
any
flow void.
flow void. The other thing important I want you to learn here is that you can see always look at the gradient echo. Sometimes you do see a black line of a thrombus on the gradient echo, not on this. Here in this case, all other vessels are looking as black except this, the vertebral artery. But when you look at the diffusion weighted imaging, which was here, sorry, the flare imaging, look at this, the flare. There's a
Yes.
signal change in the tonsil,
Mhm.
correct?
Yes.
And if you look at the diffusion, here you go, you have got a medullary infarct. This is the anterior right half medullary infarct. That is a classical with the vertebral artery. Okay?
Yes.
So you see absence of signal in even on the normal study of the brain with such a strong history that we gave you. There's a vertebral artery signal loss. There is diffusion restriction, and that goes in with the vertebral artery perforator infarct involving the medulla. It's a classical picture.
Mhm.
Okay. So what
Okay.
will you do now here? The next question before the examiner asks you, what are you going to do further? What will you do?
I would do a CT angiogram to rule out vertebral artery dissection.
Yeah. So there
And
are two things that you will do. One, you will do a CT angiogram to rule out. One was the vertebral artery dissection, and the second,
steel center.
embolic.
Oh, okay. Embolic.
Third,
Uh,
atherosclerotic. You can have vertebral origin stenosis leading to vertebral occlusion. So three things you want to rule out.
okay.
Atherosclerotic stenosis leading to occlusion, embolic coming from the heart, getting thrombus lodged and occluding the vessel, and the third is a dissection.
Mhm.
Correct?
Okay.
Perfect. And also you will go to, because this is an acute infarct, you would straight away talk to the stroke team, because you can't let this patient go home. You have to inform the stroke team, because these days, once they rule out the hemorrhage, they immediately put these patients on dual antiplatelets.
Okay.
Correct?
Yes.
Okay, so that's what something you need to know about. Good, excellent. So to sum up for the audience, right vertebral artery loss of signal void, diffusion restriction, and the flare signal change, subtle signal change of this area that we see. This you can see here the signal change. So this is telling you that you got a problem here. Okay.
Okay.
And what are you going to do? CT angiogram and stroke team review. Okay. So we move on to the next case. Okay. Department with a history of, uh, let me just read the history. Slight loss of vision in the left eye, which is progressive, query optic neuropathy. So there is a CT scan volumetric that got done, and I'm going to show you. This is a volumetric CT scan that got done, and that is the CT you are seeing. History of slight loss of left eye vision, which is progressive, and they are querying, the optician is querying any demyelination or compressive lesion or any pathology that explains the left eye vision change. I will change the window a bit for you.
There's some hypodensity at the left basal ganglia, I assume, and okay.
Yeah, so you see a low attenuation in the left basal ganglia. In
Yes.
that region, what else you want to see? Remember, whichever study you have to get the maximum out of that study. What else would you see? You would change the window
Yeah.
to look at the bones. You would look at, you can see here the orbits. You want to see the orbits. So you get the maximum benefit out of that study. You look at the optic canals and the Clanard process, and you want to see there is nothing in the sinuses. So all those things you want to see while the CT is there. Okay, so what will you do now?
Um,
And what do you think? First, what do you think? And the second, what are you going to do now? This is the CT that has been given to you.
can we go through the scan again, please? I want to
Yeah,
check.
no problem. No
Here.
problem at all.
Looks like this one. Here we have density. And then
Yeah, carry on. You keep speaking so that I know what you're talking and thinking.
I'm trying to look at the cavernous sinus, but
Cavernous sinus, here you got. This is the cavernous sinus.
is it a little bit the left one hyperdense than the right, or is it just technical?
I think, yeah, remember this side is a bit up than the other side. So you may
Yeah.
expect a bit asymmetry. But
Okay.
a good thinking that is it real, not real, but then you look at the asymmetry and try to justify, is it? Okay, so I will help you here in view of the time. I'll help you that what you see here is that there is low attenuation here in this area. There is no CSF visible, low attenuation change, and the rest of the findings we discussed, nothing in the orbits. So you tell the examiner, I can't take this further. However, I suspect there is a problem in this area and we should consider an MRI because the patient is losing vision fast and we want to see what is going on in this region. Yeah, correct?
Yeah.
Okay, so the MR gets done and this is the T2 that you see. So here is the top going down.
Okay. So this is axial T2 of the brain. There is a lesion that is appears mainly T2 hyperintense, mainly centered in the supracellular area, displaying the circle of Willis vessels around it, extending into interpeduncular area and the floor of the third ventricle up. I think it's pushing the floor of the third ventricle up and exerting mass or compressing. There is a secondary edema in the left medial temporal lobe and left basal ganglia.
Okay, so again, as I said to you, you have to determine the three things in the brain, on the dura, outside the dura. Okay, so remember, in the cord you have got the intramedullary, intradural, extramedullary, extradural. In the brain, it is in the parenchyma, arising from the dura, or outside the dura. This is for tumors. So, what do you think? It is it
think
arising in the parenchyma? Is it outside the parenchyma, or is it totally outside the brain?
no, outside the parenchyma, but inside the dura.
So, are you adamant that you're going to only look at this axial section and you're not going to look at any other section in your day-to-day practice? That's how you do?
No, I would check like the T1 and I would check the flare.
So here you go. So you have to ask the examiner, I would want to see sagittal or coronal or some other view. You know, this is my day-to-day practice. Yeah. So here you go.
Okay, again, there is a mass centered in the supracellular area, mainly a hypointense signal on T1 with anterior solid component seen anteriorly. The pituitary gland is seen separate from the mass. The mass is, can we move more? Yes, please. Pushing the floor of the third ventricle, or is it extending down from the third ventricle?
Yeah. So sum up this sequence. So what you said to me that it is separate from the pituitary gland. It is extending in the floor of the third ventricle. What else did you say?
Mainly cystic with anterior solid component.
Anterior
Um,
solid component, cystic. What is the other very important structure here that you have to determine is it arising from it or not?
the hypothalamus and the mammillary bodies, maybe.
No, the
No.
optic chiasm. Remember, the
Yeah.
optic chiasm goes, you are blind.
Yes.
So you have to determine where is the optic chiasm. Is it arising from the optic chiasm or it is displacing the optic chiasm? That's a very crucial question for the surgeon.
Okay. Can we
So how will you differentiate?
have a coronal?
So we have a coronal. Here is the post-contrast coronal.
Okay. So no, I don't. Okay, we're moving anteriorly now. Okay. So going back.
Basic question.
Here.
Basic question. Is it arising at the planum or is it arising in above the sella? Because your thought processes will change.
Yes.
I will give you the sagittal as well.
Yes.
So where is it?
No, it seems to be centered at the sphenoidum planum. Yeah.
Okay,
Not
so what is the lesion that arises at the planum?
well, it can be meningioma.
Yeah, so meningioma arises at the planum, but is it really arising at the planum? Because solid and cystic like this is not
I
the
would suspect
meningioma.
craniopharyngioma more.
Correct. The other very important differential is the craniopharyngioma in this. And what is the other? How will you separate the optic chiasm with a T2? You will, if you
Going
look at,
anteriorly.
you follow this is your optic tract. Optic
Yes.
tract, it is being displaced. And then you try to look at here, you try to look at where is the optic nerve going, it is separate. And the chiasm, this is your chiasm.
Has
It
to be
is,
stretched
this
and
is
moved
your
to the right.
ACA, so it is elevating the chiasm on the sides. And
Yes.
other thing important is, it is not sitting on the planum. There is a cystic part which is touching, but the main epicenter of the tumor is in the
Supracellular.
suprasellar region. And it is causing edema in the
Left basal ganglia and medial
correct.
aspect.
Correct. So what by virtue of location and this scan being young looking patient scan, solid and cystic, what becomes your main diagnosis?
Craniopharyngioma.
Correct. Well done. That is how it works. So it's a craniopharyngioma. But to the examiner, you will, in your description, you will say, when you have separated the optic chiasm, you will say, I've separated the optic chiasm, so it is not arising from the optic chiasm. Since it is, the epicenter is in the floor of the third ventricle, suprasellar, and it only touches the planum, and it is cystic, with some solid component, this does not have a primary feature of a meningioma. So see how in my description I am touching the differential but negating it as well. That I've thought about it, but I do not think it is. Correct?
Oh, yes.
And also, you can say that I can separate the circle of Willis vasculature, so it is not a thrombosed aneurysm. So this means you have thought about it, but you have negated it. So you have given the differential, but said, no, this is not the case.
Okay.
So what will you do?
I will inform the neurosurgery team so that so that it can be discussed in the MDT to discuss if
Correct.
there like excision or surgery to be done.
Okay. Dr. Sami, do we have a time for a small quick case?
Please go on.
Okay. Because I think this girl needs, candidate 3 needs one more case. Okay, no problem. Okay, so the last case coming to you is This is a patient which came to us for stroke, and the thought process was that the history given was aphasia, 4 a.m. today, lies at adjacent hospital, NIHSS score of 22, left M1 occlusion, and I would straight give you the CT angiogram.
Okay. So
Okay, so here you go. I'm going to start from the top.
Okay.
So they were suspecting left M1 occlusion.
Okay, so
On clinical basis. I'll give you the vessel as well.
so left M1 seems okay.
Okay, so I'll change the window so that you can always, for the general audience, always have a window so that you can see through the vessel. So see, I can see through the vessel. So always have a window that you can see through the vessel when you're looking at the CT angiogram.
Okay.
So going down.
Both internal carotids and vertebrals are patent so far. It's going fast. Okay, both common carotids are patent. Multiple thyroid nodules incidental. Okay.
Yeah, well done. I'll change the window a bit.
Okay, then we have at the arch. There are multiple filling defects at the left pulmonary, main pulmonary, and at its bifurcation. Can we zoom out the image, please?
Yeah.
Okay, I need to check the right side as well. The right side is only partially covered, but I think there is also a filling defect, extrinsic at the right side, but it's like a saddle aneurysm at the left side, thrombus at the left side.
Well done. Well done. So that's what I wanted you to pick up. Whenever you are looking at CT angios, you must look at pulmonary vasculature. You must look at lungs. You will be surprised. You will pick up cancers. You will incidental cancers. And in this case, there was a large pulmonary bilateral venous thrombus, and that was and this patient was considered unfit for any intervention. We could not see an M1 thrombus, and given such a large thrombus, it was considered unfit for any intervention of any sort, and this patient later on died. So the moral of the story is always look at other parts of the brain and the neck whenever you are looking at the CTAs. Well done.
Thank you,
Excellent.
sir.
Thank you. Okay. Dr. Sami, I'm okay with that now. Thank you.
Thank you very much, Dr. Jadoon. Brilliant cases, and I'm sure everybody learned a lot. So we hope to see you very soon again on our forum.
No problem. With pleasure.
So there were 3 candidates today. Next session, next Thursday, I think I'll take and I'll